Thank you for joining us today. It is in fact the last installment of our keynote series as part of the Hamlyn Symposium 2021 program. As next week, it will be my colleague Dan Elson who will be leading on the moderation of the last keynote in the series. And today I'm absolutely thrilled to introduce a colleague from the Politecnico di Milano, whose name is Elena De Momi. And we have known each other for, gosh, almost 2 decades and have been working together for over 1 decade on many European projects in healthcare robotics. So Elena is associate professor in electronic information and bioengineering. Is professor in the electronic engineering department at Politecnico di Milano, where she co-founded the Neuroengineering and Medical Robotics Lab in 2008. With an MSc in biomedical engineering in 2002 and a PhD in bioengineering in 2006, both from Polyme. She's currently a senior member of IEEE, associate editor of the Journal of Medical Robotics Research, International Journal of Advanced Robotic Systems, Frontiers in Robotics and AI, Medical and Biological Engineering and Computing, and the IEEE Robotics and Automation magazine. Don't even know how she does all of that. Since 2016, she's also become associate editor of ICRA and IROS and BioRob, and is the area chair of MICAI. And we're working together on ICRA 2023, so it's going to make its way to London in a couple of years. Her academic interests include computer vision and image processing, artificial intelligence, augmented reality, simulation, teleoperation, haptics, medical robotics, and human-robot interaction. She participated to several EU-funded projects in the field of surgical robotics, and a couple of them we have worked together on, such as Robocast and Active. And she's the PI for Polyme on our current project on neurosurgical needle steering, codenamed Eden 2020, as well as being a consortium member of Atlas and Artery. She has been an evaluator and reviewer for obviously a number of European Commission framework programs, including FP6, FP7, and Horizon 2020. I am delighted to introduce her talk today, which is entitled Strengths, Opportunities, Weaknesses, and Threats of AI in Robotic Surgery, which could not be more timely and a better fit to the symposium program. Thank you, Elena. And if you could please share your screen, that would be wonderful. Thank you.
Thank you for the Enando for the introduction. So I don't know whether you can see my screen now.
Yes, perfect.
Okay. And thank you to all the attendees for listening to this presentation, which I hope you will enjoy. The presentation of today regards the possible role of artificial intelligence in robotic surgery based on the experience that we have had in our laboratory in the past years. So the laboratory is depicted in these pictures here. We opened a big center for robotics, which is named Leonardo Robotics Lab at Politecnico. We opened it last year, right before the pandemic, and then we had 2 months of shutdown, but then all the activities have been restored. So the laboratory is not dealing only with robotic surgery, but also robotics for human-robot interaction, for industrial application, drones, and so on. My corner of the lab is dedicated to robotic surgery. And we have also a Da Vinci research kit there, so we can also play with the vision system, the advanced vision system of the Da Vinci. The lab is full with PhD students, some postdocs, and a lot of master students willing to work with us. So the concept of the talk regards robotic surgery. Of course, robotic surgery has been is now an asset in surgery, so because there are clear advantages which have been demonstrated in papers. But so there are still some open issues, some open points, and in these open points, artificial intelligence can play a role. Why? In 2 ways. So we have seen artificial intelligence in its double approach, so with a top-down and a bottom-up approach. And all these tools can have the final aim of increasing the intraoperative awareness of the surgeon and the safety of the surgical action. So from a bottom-up approach, we can learn from data. So in all the surgical operation, we can acquire a great number of data, images in particular, From these images, once they are properly annotated, and we will see in the next slides what does it mean, we can derive knowledge and we can use this information to improve the surgical outcome, but especially to make the intervention safer. So bottom up means starting from data, and data need to be collected and properly stored. We can also include and combine a top-down approach, meaning that we are including the previous knowledge of the surgeon, the experience of the surgeon, and we can formalize this knowledge in terms of rules. So there are these two approaches in artificial intelligence, and the aim of our research is to try to combine them together. Artificial intelligence has been used and proposed in clinical decision support systems. So what does it mean? It means that based on data and the clinician experience, we can help the decision making. So when the patient enters the clinical facilities, the decision on the best treatment, the prediction of the possible outcome according to the treatment that the patient is undergoing into, can be helped by artificial intelligence. And this theme has also entered the European funding schema. If you have a look at the Horizon Europe program, you will see that in the F pillar, a lot of calls combine artificial intelligence and clinical decision support system to achieve a better decision process, so to improve the decision process that has to be made on patients. But what are the ingredients that we need? We need data, so we need a lot of data to derive knowledge, but these data have to be annotated, means that there is an expert who is classifying data, so providing a sort of gold standard so the system can be trained on. But of course, the more data you have, the better generalization abilities you can have. But in order to properly collect and annotate data, this is a time-consuming process. So the recent applications are trying to generalize based also on a limited amount of data. And we need to properly storage the data, so to share data and to store the data so that they are safely kept and there is no leakage of these data going around. And as said, the important part is to share data. This is also based, so you can think about what happened with the pandemic, the possibility of developing vaccine in so few time was also due to the fact that as soon as the sequencing was achieved, the sequencing of the virus was shared between the clinical institutions. So sharing knowledge means advancing science faster. In the robotic application, so what does it mean to include artificial intelligence, include data, and include rules in the robotic application? We can provide a system which is aware of what's going on, because the camera system of the robot can see the scene and can increase the interpretation of what is happening inside the patient. If we see more, we can know more about, for example, possible critical situations, possible regions that have to be avoided by the surgical tools. We can provide a decision support system, so the surgeon during the operation can get some advice from the control system of the robot. Eventually, the system can perform some tasks in an autonomous mode. I think that in the previous talk, some of them I also attended, some of the other speakers will introduce the concept of autonomy in surgery, and some tasks were made possible to automatize the suturing, but also tissue retraction, for example. And overall, the final goal is to improve the safety, so to increase the safety of the patient, so to avoid surgical errors, as we are doing in autonomous vehicles. So the trick, so the motivation for increasing the autonomy of cars is to increase the safety, because you have automatic braking system, for example, or you can have systems which are assisted in staying into the path, the road path, or you can have a system which can alert if something dangerous is perceived. So in parallel with the autonomy increased, so the classification of the different level of autonomy in a vehicle, there's been this classification, this taxonomy about the level of autonomy in surgery. And again, I think that this topic has also been covered in the past talks. I just wanted to point your attention to the fact that all these steps, or these autonomy level that we are accepting in the robotic system, is the motivation for accepting autonomy is to increase the safety. So we shouldn't be scared about seeing this, let's say the robot is able to do some task autonomously, because this is the system in this way can be safer, can reduce the possibility of making mistakes. So what is the input data in robotic surgery? So the data, the past data that we can collect, and on the basis of which we can develop our knowledge. In minimally invasive surgery, the system is equipped with some sensing possibility, and the sensing is made of the camera system, for example. And from endoscopic video, we can retrieve a lot of information about where the robot is acting inside the patient. And endoscopy can be used in several applications, and these are just some examples of possible images that you can get using endoscopic system. So I divided my talk in 3 main steps. So the first 2 are dedicated to how endoscopy can help in, first of all, seeing more. So artificial intelligence applied to endoscopy to see more with respect to just the images provided by the endoscope. Using this information can also increase the safety of the control in robotic surgery. And the third part is dedicated to autonomy in an example of a project that we are actually doing with Professor Rodriguez Ibaena in the context of the Eden 2020 project, where the path for the steerable catheter is computed autonomously. So this is the concept of reaching autonomy in surgery, starting from the images. So playing with the images with the bottom-up approach, so you see the label bottom-up, and all these steps can guide us towards the reaching the final autonomous task. So playing with the images, we can, for example, select in the endoscopic video stream, we can select important images and disregard the non-important ones. So we can base, for example, the diagnosis only on a subset of images which are the important ones, disregarding, for example, the non-informative frames, the blurred ones, or the one with specular reflection. So we adopted an approach which is called the transfer learning. So we use a pre-trained network on several images. So the network were trained on images, so natural images, and we applied those pre-trained network which were fine-tuned on our narrowband images on laryngoscopy. So the district that we are speaking about now is the one of the larynx. And with this approach, we were able to, in a robust way, to transfer what the network has already learned on natural images in the classification part of our images from the endoscope, from the laryngoscope. With high accuracy, we're able to disregard non-informative frames. Another way of combining the images of the endoscope is applying, in this case, it's sphetoscopy. I think that Professor Stoyanov spoke about it, a couple of days ago. we were able to perform stitching of the panoramic view. So playing with artificial intelligence, playing with the images with the machine learning approach, we were able to stitch the images to increase the view of the endoscopists during fetal surgeries. Okay, so now so what else is possible just based on the combination of several data? So having systems, having models that can learn from annotated images. Annotation means that we are supervising the classification project. Annotating, so inputting our knowledge into the image bunch. So we can perform tissue segmentation, which can also be semantic if we are tagging the images also with the name of the structure we are seeing. In this case, the work was done in collaboration with the German Cancer Center, and one of my ex-PhD students work on the semantic segmentation of these multispectral images. Multispectral means that these images are not only RGB, but it's increasing the spectrum of the frequencies that were used during the image collection. So detecting these, so combining and constructing these superpixels, so these regions inside the images, and using statistical approaches as giving a measure of the confidence of the classifications, allowed us to provide a more robust classification of the images. So we were able to detect, for example, in this case, these regions that you can see here, gallbladder, liver, spleen, and intestine. And all these superpixels were also labeled whether the classification was, we were confident or not of the classification results. Combining these statistical approaches, we were able to to interpret the images, so detecting the tissue and also tagging the tissue with their name. Another approach is used in fetal surgery when we need to identify the membrane between two twins, so when they are still unborn. There is in the placenta, there is this membrane that separates the two twins. And on this membrane, we have to identify some vessel in order to perform ablation. So this is what the endoscopy is seeing. And we want to use annotated data to identify in an automatic way the membrane, and to then to help, so to have let's say an informed approach in order to perform this intervention in a safer way. So this is what the endoscopist is, the surgeon is seeing during the operation. So this is the membrane that you need to detect. It's really hardly visible, also by naked eye. And so using past images, so annotating the images and combining information from past interventions, we were able to detect with high accuracy the membrane, and then to implement a system which gives visual feedback to the surgeon, so that he accurately can determine the position of the membrane and the vessel in the membrane, so and perform the ablation. And of course, for this approach, since we can rely on past data, annotated data, we introduced this innovative segmentation procedure using a generative adversarial process to have a segmenter. So the first layer is segmenting the images. And then the second layer was implementing a sort of critique of the proposed segmentation part. So this is the first segmenting layer, and then there is a critique on the feedback loop. So with this approach, you can see here, so this segmentation network on the feed-forward loop, and the critique one in the feedback loop. And with respect to state-of-the-art network, we achieved better results, so more accurate and more robust, so in the video that we used. So this approach was also improved using also the temporal feature, because we are speaking about videos, so the information of 2 consecutive frames is correlated by the fact that there is a temporal exchange in the temporal shift in the images. And then, so using the temporal information, we were able to further improve the segmentation results. So the first part was only related to improving the awareness. So seeing more with an automatic approach that is highlighting structures in an automatic way. But this information, since we can see, we know where the structure are, we know where the instruments are, knowing this information, we can also act on the control of the robot. So if we have a system which is robotic inside the operating theater. So in order to detect the tissue and to track the tissue motion during the operation, we need to we implemented this system in the past years. So tracking means that we need to know where the tissue is in all the in a time frame. So because the tissue is moving, because the patient is moving, so because there is interaction with the surgical instruments, and these action, and also because there is pulsation, for example. So the approach here was a model-based approach, so not a deep learning approach in which it's model-free based on the data. The approach that we implemented in the past was based on a model. So we have a model which was trained by the different frames. The important part was when we detect a failure in the tracking, the model needed to be reinitialized, because we have to be robust to possible occlusion due to the instruments, possible situations in which the area is out of the field of view, or we can have also scale changes or blurred images or smoke inside the field of view. And this is what we achieved in some years ago, in 2018. So with the model-based approach, in tracking this vessel that was highlighted and segmented here. So you see, now we are moving towards a model-free approach, so using deep learning in order to provide a robust tracking of the tissue. On the other side, we need to identify and track the instrument motions, and this work was done in collaboration with the UCL. The instruments were the structure of the instrument was simplified using this joint that were identified automatically using a deep learning approach in subsequent frames of these simulated surgical action. So it was done on a phantom, but these instruments were actually real. So once we have the position of the instruments and on the tissue in the frames, in the 2D frames, we need, in order to control the action, we need to determine the position in the 3D world of the instruments and of the tissue. So once it is done, we were able to develop, so integrate everything inside the Da Vinci Research Kit. And these were some experiments we did in the lab, in which you can see here that the user was asked to displace an object from the left hand to the right hand, pay attention not to hit the structure that needed to be avoided. And there was the information about, you can see here, the information about how close the user were to the structure that needed to be avoided. What we demonstrated is that if there is this information about the distance between the instrument and the region, the task was performed faster because the user felt more confident, because there was an alert system in case the instrument was too close to the structure to be avoided. So Again, context awareness. Let's move to the automatic understanding of the surgical action. So in order to understand the workflow step, you need to annotate long videos. So we took videos from the operating room. The procedure was nephrectomy. And we spent hours with surgeons to annotate, so to give information about the surgical step and the surgical step duration, manually annotating all the video frames. Combining, so this was the first combination that we tried about bottom-up and top-down approach, because from bottom-up means that we took all this annotated video and then we train our system in order to classify, to have the classification of the videos into the proper workflow step. But we also derived the knowledge from the surgeons, and we built this sort of workflow, which was based on ontologies, so semantic relationship between concepts, which describe the surgical process. So combining the top-down and so the rules that we knew before about what was the subsequent actions list of all the surgical steps, and the bottom-up approach, including all the video taken during the surgeries, we were able to provide a robust classification of the surgical videos. So these are examples of what we achieved. You see, there are the videos and the name of the surgical steps, which are appearing automatically because the system was able to recognize with high robustness the surgical step. This could be useful when you need to tailor the control of the system according, for example, to the surgical step. The autonomy that we introduced into our Da Vinci Research Kit was the autonomous movement of the camera. And the approach, which was suggested by two PhD students, was to move the camera at the center, so following, for example, either the right instruments or the midpoint between the two instruments which are in the field of view. So we performed experiments, a lot of experiments with 12 surgeons coming to the lab and performing experiments on ex vivo tissue. And the ex vivo tissue was placed so that it resembled some clinical applications, some actual surgical applications. And they selected this uretrovesical anastomosis and this surgical approach. So what we measured with this huge amount of experiments is that we compared the standard approach, so with the manual movement of the camera and the autonomous movement of the camera. So from the first analysis, only on analyzing only the time required to perform the actions, we didn't see any statistical significant difference. We are now analyzing further the data in order to understand, so to classify the surgical action and subdivide the surgical action in smaller steps, so to understand what were the steps that took longer and the steps that took shorter. And for the preliminary analysis, we also understood that there is a significant difference about the time, considering all the time in which the scene is out of the, so the instruments are out of the field of view of the camera system. So last bit of information will be devoted to how to include so another approach of artificial intelligence dedicated to the path planning based on reinforcement learning. Reinforcement learning is a kind of approach which is in between the top-down and the bottom-up. We have a task and an environment. We need to start from a point, so the entry point on the skull of the patient. We need to reach a target which is inside the brain of the patient, avoiding obstacles. So it's a kind of it's additional problem in robotics. It's about path planning. Also, when you have your cleaning machine in the house that has to start from the home position, going to the target position, avoiding obstacles during the path. So the environment that we have is this one. Our robot, the moving robot, is a steerable catheter, which has possibilities that you can see here of performing curvilinear trajectories within soft tissues. So what we did is that we trained the system giving rules. So the rules of the behavior of the system is to try to avoid as much as possible, try to stay away from obstacles, try to make the path as much shorter as possible, and try to minimize the curvature, because the straighter the path, the safer it is. And so also, we combine some rules because we have the experience of surgeons and our neurosurgeons in ranking the possible trajectories that the automatic system is proposing. And in order to do this, we made use of the ASP language, which is an interpreter that allows the rule to be changed in real time without recompiling the system and spending time in, let's say, needing an engineer that is behind to change the rules. And so the approach which we combined was a reinforcement learning, in which we have rules that steer the behavior of the catheter, and also rules from the expert, which can further tailor the final trajectories. And these are the results that we achieved and that we submitted for publication in Autonomous Robotics. And so here you can see the catheter with its actual dimension entering from the possible entry point and reaching the inner target within the brain. So to sum up, what is the future of robotic surgery and what is the future of autonomy in surgical robotics? So for sure, artificial intelligence will have a role, and the role, which has been already written down in papers, is that it allows reducing technical errors, enhancing the possibility of offered by robotic surgery, and also to have a standardization of the process, because the more controlled the approach is and the more, let's say, standardized, the more standardization you can offer to perform the same surgery in different centers. And autonomy as well, we provide a safer approach. What about the, let's say, the things that we need to cope with? For example, ethics. I introduced before that you need a lot of data, but data are proprietary of the hospital, which is generating data, and of the patient who is giving the data to the hospital. So there are some privacy issues that have been taken into account also by the European Commission with the GDPR, for example, and by several documents that have been published on the, for example, this group of high-level expert group on artificial intelligence. So what are the ethical aspects that needs to be taken into account when developing some artificial intelligence tools in your application? So this was regarding, for example, the privacy of data. It had to be kept safety, avoiding leakage, but also to be destroyed after a while. And the usage of artificial intelligence and autonomy to prevent errors. There are also some publications about possible errors due to misbehaved of the system and misuse of the system by the surgeon. So to conclude, we have this SWOT analysis. So what are the strengths? For example, this is my main message. The strength of artificial intelligence has to be devoted in increasing the safety. The opportunities are devoted to, can be found in training systems, so having better training system, more standardized, so to also to measure in a robust way the performance of the surgeon. You can also perform remote surgery because you can have a system which can be autonomous and can perform, for example, you can have a remote assistant, remote expert assistant, and then the surgery performed on the spot. And it's very, so due to the pandemic, all these problems have emerged. and the standardization which can lead to the democratization of the surgical care. Weaknesses that we need to overcome with our research is that the need of annotated data to generalize to what is not seen already, the need of standard, the need for benchmarking opportunities, and the threats are due to the problems of who is responsible when there is a mistake to cope with the ethical issue and privacy of the patients. This is a general overview, what's next. So always try to have a vision of what will be the future in 20 years. For sure, there will be smaller system, more autonomous system, and wider system adoption worldwide. Just to joke, if you want second opinion, just ask the computer. Pay attention to the translation to clinical practice, because you need the clinical trials, a certification, and when you are proposing a method for a deep learning method and so on, you have to think about the reusability of the method. So because the method shouldn't work only on your data set, and when you slightly change the data set, everything collapses. So thank you very much for attending the talk, and I'm available for questions.
Wonderful. Thank you very much, Elena. That was fantastic. Great high-level overview of what is a topic area that is exploding at the moment. So we've got some talks and some questions, sorry. And I would remind everyone, if you would like to pose a question to Elena, please annotate it on the Q&A tab, and I will read it up for her to reply. And the first one is from Sylvain, and they say, thank you for the wonderful presentation. As a social scientist starting a project on robotic surgery at the moment and focusing on trust, I was wondering how surgeons feel about having some autonomous system in the robot likely to intervene in their manipulation. So basically, what is the human response of a system taking over, doing some level of autonomy to stop them from going too close to a tissue and so on and so forth?
Yeah, this is quite controversial. So if the surgeons perceive a resisting force on his movement, the surgeon wouldn't accept such a system. So I think that the important part is always to alert if something can possibly go wrong. And then maybe there will be a shared control of the system, and maybe the system should just alert a bit, and then if the surgeon wants to overcome the limitation, the surgeon should always be in the possibility of overcoming the restraint from the system. This is the only way for making them accept such a thing. We accepted in the car that the car can brake, can, let's say, decelerate if there is a danger. They will accept this in surgery, but they need to have the possibility to overcome the restraint from the system.
Yeah, so I agree, and I would add to that it also depends what part of the surgery is being automated. Yeah, there are certain aspects of a procedure that a clinician doesn't feel are high risk, in which case maybe you can get away with a little bit more autonomy, and there are those areas where a clinician wants to remain fully in control and so on. But absolutely an open question as of today. And so Sylvain actually follows on with a second question, which is, I'm thinking about trust issues. Surgeons can trust 100% a robot that will reproduce their action with even less precision, example, less tremor, but knowing the robot is likely to act autonomously at unexpected times might change this, I imagine. And I think we sort of followed it already, in the sense that, yes, it is very much, an open question as to how a clinician would perceive it, and I guess what we could do as clinicians to fix it. So let's move on to the next question, which is from an anonymous attendee, and he says, or they say, in fact, how do you think explainability should be handled to offer the patient and surgeons in these black box approaches a clear overview of what is happening and why, And great talk, by the way.
Thank you. Yeah, this is the point. Explainability is the future. So in the deep learning approaches so far have been, let's say, black box, and the only way of tracking what was the network was doing was backtracking the different layers, understanding, for example, in an image, what was important in the classification, what was disregarded by the network. Also in decision support system, the clinician has to understand what the important features. But this can also give, for example, in the decision support system, you are combining several data and then you're making your decision based on some data are important, some data are not important. But then the backtracking of the classification process can highlight something that you didn't know. So there should be new trials to understand what if the network is actually detecting something that the medical knowledge haven't detected so far. In vision, I think that the explainability plays a role, but maybe it's, let's say, it depends. Less important. It's less crucial to understand in an image, for example, what were the features that the network thought they were more important or not. This can this can help tuning, for example, the classification, the segmentation, can leverage in providing better algorithm. But I think that the crucial point is really when you're basing your decision, the treatment selection for the patient on the basis of black box approach that is suggesting to do something rather than something else. And it also worries me about the new program, the Horizon Europe program, because in the health pillar, you see there is a lot of artificial intelligence, trustworthy artificial intelligence for decision support, for doing a lot of, let's say, steps of the clinical approach should be based on artificial intelligence. But isn't it that clinicians are trusting too much, or have too much, let's say, expectation from artificial intelligence at this very moment? So maybe the clinician no, but for sure the policymaker now have too much confidence on what artificial intelligence could do into these approaches. So I don't think we are there yet. And also some calls are asking for clinical trials on decision support system based on artificial intelligence. Clinical trials means that you have a random allocation of patients, and some of them should go for the new approach, some of them should go for the standard approach. But I don't know whether we are there yet.
Yeah, I completely agree. So there's I'm not sure it's the same audience member or not, but they say, do you think ultimately these black boxes will create a report reproducible for patients and surgeons? And if so, what do you think we should consider? I'm going to read it again. Do you think ultimately these black boxes will create a report which is reproducible for patients and surgeons? And if so, what do you think we should consider?
Well, I think that if, for example, in the approach I presented about the automatic classification, identification of steps based on the, let's say, identification of the automatic identification of the surgical workflow step, I think that in the end you can have a report. So this is what also surgical data science is searching for. So and also some companies are working on this. So I think that Professor of companies is try to have a report in the end of the surgical action based on what on the images. And this, if you classify the images and detecting, for example, the duration of each task, you can in the end have a report, and you can use this report, but of course all the ethics and the protection of the user and so on, so the ethical aspects of how to use this data will raise, because for example you have for each surgeon how much time is spent on doing something and doing something else.
I agree. Elena, so both you and Dan actually explained quite the progress that has been made using deep networks on imaging-based data. And I wonder whether you have a feeling about non-imaging data that is pertaining to the surgical operating theater, and how that could be used within this sort of context, and maybe what the timeline for that is. Yeah, because obviously there's a lot more data with a surgical robot than just the images. And I think the images are leading the way, and we understand how to deploy some of these algorithms well. But do you have a feel from where you sit as to what would the next thing be? What other source of data would be useful to
So
mine?
in robotic surgery, you have the kinematic data. So there is the data set that was produced by Johns Hopkins that are combining either the images, but also the kinematic data. So from the encoders of the robot. So also based on that, you can derive some information, but of course, in minimally invasive surgery, the greater amount of information comes from the vision, because you have all these pre-trained network trained on a huge amount of natural images, amazing work already done. And so it's easy to translate this concept into the images coming from the endoscope. For the in bioinformatics, so the genomics and transcriptomics and proteomics, in those cases, deep learning can be used also to classify, to make decision in a support system, to have classification of patients' condition, predictions of outcome. So, for example, you can predict the survival rate or the progression-free survival based on any kind of data. So, in those approaches, let's say the path is longer, I would say, because you don't have all the, so you cannot use all the pre-trained network on images. So there is a transfer, so a bigger transfer of knowledge of the learning. But of course, that has already been done. For example, what we did in the past, for example, to classify using DNA sequencing, we translated the DNA sequencing into images. So we use the same concept about image classification.
So on a practical note, right? So you say kinematics, and I guess we more or less have all been able to work on the DVRK, but now that I work with it a little bit more than I did before, I can absolutely see that it is rather dated and aging, because it's now a platform that is almost a decade old. So as the DVRK becomes obsolete, what do we do as a community? Do we convince Stryker to give us a Mako platform with the same open architecture, or?
I would say CMR surgery, the Cambridge robot. Yeah. So they have, I think they have to become richer so that they have the possibility of giving systems.
Donating all systems, yeah. But do you know if Intuitive Surgical will be making available because obviously now we're 3 or 4 generations on with respect to the systems that made up the bulk of the DVRK family. Do you think that there is any plan in Intuitive for them to share a later version of their hardware? Or? It
depends how distributed it will be, because I think that the ones that now they are giving to the research communities, because there has been a replacement. So by the time there will be a replacement of the current system, they will leave the current system to the research community.
Yeah. Interesting. We've got an email, a question from an anonymous attendee again. It says, in the future, do you think responsibility will be on engineers, surgeon doctors, or new career will emerge, like a deep learning surgeon or a doctor engineer? That's a very good question.
Yeah. I would like to know the name of the person who asked such an interesting question. So I think that is also giving the answer. So new characters are emerging. So also, for example, in Italy, they are opening a lot of new graduation.
That is true, actually. Yes. Good point.
About medical. So they are in between medical and engineering. So in Milano, we have biomedical engineering and medical. In the southern part of Italy, there will be information engineering to get computer science engineering and medical doctors together.
So that is you, isn't it? It's Politecnico and Humanitas are running this sort of joint medical engineer degree. It's very cool.
So we started, but now things are opening up because other universities are doing the same, which is important because it means that the message was accepted, because the medical community was not that keen of changing, because it's let's say technology technology-driven approach. You're making your diagnosis and so on based on what the technology is telling you, while the traditional approach of medical doctors is, I want to see you in your face, and from seeing you, I can judge what you have. So it's a kind of transition. Regarding the question, the responsibility, I think that first, yes, no, it won't be left to the system, because you cannot blame the system if it was not used properly. So there should always be the human in the loop, and the human who is responsible of the system maintenance, the system usage.
And you come up with a double degree, Elena. So it will be a qualified doctor and an engineer
with a bachelor. So you have a master in medical in surgery, medical and surgery, and medicine and surgery, and a bachelor in engineering.
That is very cool. I hope that we follow suit, because I've always, if there is one regret I've got in my own career, is that in infinite time, it would be great to just get a basic medical degree so you can scrub and really sort of ascertain with your own senses what it is to be a clinician in the operating theater, because I think many of our engineering students and researchers struggle to identify what the real problems are when you actually have a patient on the operating table, and it's very different from what you see in a lab. So we're almost out of time, but Elizabeth has one question I wanted to share with you. And she says, do you think the use of AI in surgical robotics is strongly associated with the surgical application, or more strongly associated with the autonomy of the robot to perform the surgery? I'll read it again.
Yeah.
So do you think the use of AI in surgical robotics is more strongly associated to the application in which you're applying the AI to? So basically it's laparoscopy or endo or ortho or whatever, or more strongly associated with the autonomy of the robot? So basically it's more to do with how the robot operates as opposed to what the robot does. So is it going to be more useful to deploy AI to make the robot work better, understand better? So this is basically more human-robot interaction, how it milks the current interaction between the robot and the clinician in order to improve that relationship, or is more towards understanding how best the robot can support a particular surgical specialty, like laparoscopy or 300 operation and so on?
I think artificial intelligence, data mining, and so on can be useful in all of these. So you can have context awareness, means that you see more, or you can let's say identify structures, you can let's say alert whether something going wrong. So because you have an intelligent system that is assisting the surgeon, and also this intelligent system can also assist the robot, because you don't have just a model-based control, but you have let's say reinforcement learning in the loop. So the robot could be safer and more robots with respect to perturbation. So it's not just a PID control, but you have also something which is smarter, better trained. So
I guess the summary is, I guess, both. Yeah. Right. There is scope for both. Great. Okay. So we are officially out of time, but thank you very much for a fantastic presentation and certainly for a very engaging Q&A. Just reminding the audience that obviously this presentation, like all previous presentations, will become available on the YouTube channel for the Hamlyn Symposium. And remind everyone there is one more keynote next week. But there is also a launch of the white papers that were spearheaded by the UK research community in the broad area of robotics, which is supported by the UK RAS, which is the UK Robotic and Autonomous Systems Network. And we will have our own white paper on surgical robotics launching tomorrow as well. And it is a joint white paper that was co-edited by Pietro Valdastre, Christos Perceles, and myself, with the support of UK RAS, and co-led by Anna Cruz-Ruiz, who is the project manager for the robotics community here at Imperial College. And it is a very, very nice summary of the collected vision in surgical robotics for the community here in the United Kingdom. So I would recommend you come and see the launch tomorrow and eventually download the white paper. And finally, reminding everyone that on Friday next week, so the 29th, we have our closing ceremony. And there will be two esteemed speakers that I'm not going to tell you about. I'd rather you go on the Hamlyn website and check, but I'm sure you'd want to come and see them speak. And obviously, there's also going to be the award for the challenges on that day. So without further ado, thank you very much, Elena. Thank you to the audience for being with us, and I will see everyone next week. Thank you.
Thank you so much.
Ciao, Elena.
Bye-bye.